Magdalena Janus to give joint CHES rounds that are partnered with the Leong Center for Healthy Children today. For those of you who are not familiar with Dr. Janus, she is a professor in the Department of Psychiatry and Behavioral Neurosciences and the Offord Centre for Child Studies at McMaster University, where she holds a chair in early childhood development. She knows everything there is to know about the early development instrument, which is a tool that's used widely and internationally to measure children's developmental health at school entry. She will be speaking to us today about pre-pandemic data on population level patterns of children's developmental health. Are they still relevant? So on behalf of CHES and the Leong Center, it's a pleasure to welcome Dr. Janus.
Well, thank you very much. I really appreciate the invitation and an opportunity to speak. I would just like to add that I'm giving honor and thanks to the Haudenosaunee, Anishinaabe, and Mississauga of the Credit First Nations, who are the traditional inhabitants of the lands where I'm speaking from. So I really have to give you a fair warning that I'll spend most of my talk talking about the pre-pandemic data, and only towards the end I'll answer that question, just so that you're aware of that. And I would like to start from what I see as kind of the beginnings and the roots of my program of research. It may have been said before, but it was really Jeffrey Rose who, in a publication in the early 90s, said, and in relevance to the prevalence of cardiac disease, said that large number of people are at small risk give rise to more cases of a disease or disorder than a small number at high risk, which was also dubbed as a prevention paradox. And you know, it's beginning to be very ubiquitous that you really have to think about prevention in those terms, especially in the current times. This concept was taken from the cardiac epidemiology by Dr. Dan Offord and his colleagues, and used in trying to understand the prevalence of mental health disorders among children and youth. And in order to do that, they ran a study that was called Ontario Child Health Study, or OACS, where a representative sample of 4 to 16-year-olds in Ontario was, it was a study of about 4,000 children, in order to establish the prevalence of mental health. And there were a few numbers that kind of were highlighted by that study. The overall prevalence of at least one mental health disorder in that sample was 18.1%. Among children who were coming from the lowest socioeconomic households, there were fully 1/3 that had at least one mental health disorder. However, when you looked at all the children who contributed to those 18.1%, only about 7.3% came from those low SES households. When you looked at the whole group of those with mental health disorders, 2/3 of them were coming actually from relatively well-to-do families. So that basically led to this understanding that children's mental health is everybody's concern. It's really not just the field for psychiatrists to attend to, but the more we know about them, the easier it will be to prevent them from happening and making a huge difference to children's lives. The other thing that was happening more or less at the same time was, some of you may remember, the National Longitudinal Study for Children and Youth that started in the early 1990s. It was collecting sample representative of all provinces, or each province, I should say, but not of all communities within the provinces. So the results, even though they were coming fast and furious at the beginning, especially the same cohort of children was tracked every 2 years, and we saw the association of children's difficulties in terms of language at school entry, children's prevalence of problems in relation to indicators such as parental education or family income. We really, these results could not be taken down by communities and acted upon locally. The worry was that, for example, for smaller provinces, smaller provinces such as Maritimes, the only number that was being offered was for the full province rather than for each community. And the concern was that they were not be taken seriously by people who really actually had ability to act and do something about it, such as politicians and policymakers. So that need for kind of wider range of data collection was already being fleshed out with the advent of NLSC-wide data. A number of other things were happening in the last decade of the last century. WHO has put out the definition that health is more than absence of illness. Dan Keating and Clyde Hertzman published an edited volume of papers on understanding of social gradients in outcomes in life trajectories, and they coined the term of developmental health, which they felt that was a better encompassing term, because the outcomes that shown association with social determinants of health were were going beyond physical health. They were physical and mental health, behavioral and cognitive. At the same time, it was quite well beginning to understand that child development is more than ticking off milestones, whether a child can do this or that. And that school readiness is more than just being able to read letters or count to 10. And hence, the term child developmental health was constructed to mean these reflecting of the early childhood experiences at home in the community, but encompassing physical, behavioral, cognitive aspects of child development. So coming back to social determinants of health, by the beginning of this century, the gradients in child developmental health were confirmed. What it meant was that better social, economic, and physical environments were associated with better outcomes in childhood and throughout the lifetime, because they resulted in lasting impact on life trajectories through so-called biological embedding, a term coined by Clyde Hertzman and Dan Keating. And that could be happening. We know now a little bit more about epigenetics. We know about perpetuation of systems, such as that if you live in a neighborhood that has more toxins, that those toxins can get into the live stream. The other possibility is exposure to adverse childhood events that can impact development and attainment later throughout the lifetime. There's quite a lot of knowledge now on that, but it also led us to understand that we really shouldn't be asking why did this child get this disorder / problem at this time. We really should be asking, why do some populations of children have different rates of a problem than others over time and in different locations? And yet, one more thing that kind of came into play here was in the early 2000s was a report by Mike Marmot to the Social Determinants of Health Commission at WHO, entitled "Closing the Gap in a Generation." And one of they posed many recommendations, but one of the major recommendations was that early child development should be paid a lot of attention to, because it could be a powerful equalizer in preventing a lifelong disadvantage for people, especially coming from the more disadvantaged environments. And so that was the gap that they were referring to. So here in Canada, and even more in Ontario, there was the call for social reporting at the community level that came at the end of the 1990s, precisely because the understanding was that we really can't provide actionable data, easily translatable data, if we're only talking about representative populations. And sometimes you could ask a question, representative of whom, representative for who? And I think that question again comes back as very relevant right now. So we really needed data to monitor child development over time in context, reliably, for populations of children. Without this population level basis, the problem is really that we don't know what we don't know. And I don't know of a better example of this, of illustration of this point, than this data that come from a study by my friend and colleague Marnie Brownell in Manitoba. In Manitoba, the Manitoba Centre for Health Policy has been collecting and linking data on children in a very efficient manner for many, many years. But this study shows simply the association between child family socioeconomic status and percentage of passing grade 3 test. And as you can see, even children from the, when you look at all children who took the test, from children in low SES, 83% passed the test, which is actually quite a good percentage. So it may make you feel, well, really, there doesn't seem to be such a big problem. But yes, there is a problem, because if you actually look at the percentage of children who passed the test among the whole cohort of children who should have been taking the test, rather than just those who actually took the test, you see that there is quite a large proportion of children, especially in the low SES group, that are not taking the test for various reasons. But if you take a percentage of all children that particular age, in this particular group, it's only 50%, which actually really isn't a good percentage. So all these things combined led to the development of the population level measure of child development in 5 major developmental domains. And because I'll be talking about EDI data a bit in the next few minutes, 20 minutes, I thought I'd just remind you that it's in an instrument completed by kindergarten teachers for each child in their classroom. And it has 5 developmental domains: physical, social, emotional, language and cognitive development, and communication skills and general knowledge. Obviously, you can take a mean score for each of the domain, but we often look at the results in terms of vulnerability, and the vulnerability on the EDI is defined as % of children vulnerable in each domain. Vulnerability as scoring below the 10th percentile on the normative distribution of children's scores. And overall vulnerability means that a child is vulnerable in 1 or more domains. So this instrument has been around for a while. And we now have collected data for almost 1.5 million children in 12 of 13 Canadian jurisdictions. And we know that 27% of children are vulnerable at school entry, and that more boys, proportionally more boys than girls. So yes, 27%. If you look at the range from in jurisdictions, so among provinces, this varies from 17 to 42%. So again, if you look at one number, Canadian-wide, you have 27%. If you go to each province territory that worked with us over time, you also can get one number. What's the percentage of children vulnerable in your jurisdiction? But what this population level coverage gives us is also looking at each community and particularly each school. And what we actually see in those data, and I think that's actually a very shameful range, we see that we have schools in Canada where 100% of children are vulnerable in their development at school entry, but we also have schools that there are none. And that's a range that we really should be paying attention to, more than just one number. So in terms of the implementation over time, because the early development instrument data are collected through provincial, on the provincial schedules, there is no national kind of schedule that everybody would be collecting at the same time. So as you can see those, so this is a graph that plots vulnerability on one or more domains against the time. And as you can see, some of these vulnerabilities grow, sometimes they fall back. So the pattern is not necessarily exactly the same in every province, which makes you wonder, obviously, why, and makes you want to look at these data. But because the set of items that tap children's development is the same in every single province, but there are some nuances in other questions and in the way data are implemented, etc., that it really was impossible to just kind of lump all the data together and try and answer research questions with this data set. So instead, we've spent quite a lot of time, luckily funded by a CHR project, by linking child development to a customized SES index that we have developed, by So we put together the data in such a way that it would be possible to ask questions, and we wanted to ask questions at the neighborhood level. So we had to have neighborhoods that would be comparable. So we created just over 2,000 neighborhoods for those data based on the EDI record, so that we would have enough EDI information. And we also looked at over 2,500 variables from taxonomy and census, and created an index based on 10 variables, because the study was called Canadian Neighborhoods in Child Development Study Connect. We call this a Connect index, and it's for those customized neighborhoods. So in keeping with the knowledge on social determinants of health and the gradients in child development, we also see that the SES gradient measured by the Connect index exists in provinces. And here you see this for 4 provinces, for British Columbia, Manitoba, Alberta, and Ontario. And the slopes are slightly different between provinces, but the direction is exactly the same. So these are large databases, and they can help us. Understand something. And for this, and I wanted to give you an example here. There is, because the EDI is holistic and kind of has these different domains of development, it also has data questions that are relevant to children's mental health. And we're really very concerned about children's mental health right now. And you at CHES have people who have already spoken at those rounds. I listened to them, I read their papers, that will have information on children's mental health in way more depth than what we can do with the EDI data. But there are some advantages and some information that we can contribute. So the mental health on the EDI is represented by the emotional maturity domain, which includes anxiety, hyperactivity, aggressive behavior, and prosocial behavior. And some data, so this is an example of data from British Columbia, where the EDI was linked with administrative health databases for children up to the age of 14. And what they found that for 83% of children, there was no risk for mental illness. But for the remaining 17%, and they were identified in 3 different, there was definitely increased risk, and that risk was based on information that was provided by the EDI in those mental health, through those mental health items. And slightly different groupings of items predicted somewhat different profiles of mental health issues by the age of 14. And this is an example from British Columbia, but the EDI data also collected at a periodic interval every 3 years in Australia. And a very similar study came from Australia showing that 77% of children are at no risk for mental illness, and the ones that are show very similar profiles than the ones in Canada. If you take one of the domains, you can track prevalence over time and across the country. So for this particular example, I've looked at the anxious, fearful behaviors, and we hope this data will soon be out as in published. And you can see that it looks that the prevalence remains fairly consistent from year to year. And it's not that consistent between provinces. All these differences are statistically significant, but the effect sizes are really quite tiny for those differences. But it will give us a certain opportunity to look at them in the future years. So I think I would like now to come to the kind of my first take-home point about the population level data. They are really good at monitoring patterns of children's outcomes and over time and in different locations, which is answering part of the question that I posed at the beginning, which makes us wonder, well, to what extent we can use such population level data, which are broad, but really kind of shallow in terms of the depth that they cover, in order to understand special populations. So we're also lucky enough to have another study that we called Canadian Children's Health in Context Study, that Marnie Brownell and I were co-PIs, looking specifically at children with health disorders. And without any linkages to any administrative data, we have 3 major groups of children with health disorders that could be identified with the EDI data. Children with special needs, which are based on school district designation, children with functional impairment, so they may have a problem that influences a child's ability to participate in the classroom, so physical, visual, and speech. And we also, as of 2010, collect data on medical diagnosis if the teacher is aware. So for example, we have autism spectrum disorder, and in one linkage with the 2015 cohort in Ontario with administrative data, we found that there was pretty good concordance. Kappa was at 0.60. We also have, among other ones, fetal alcohol spectrum disorder on that list. And I'm mentioning that because I'll show you some data in a second. But first of all, we looked at the association between neighborhood SES and variance explained. A student of mine, Dana Zaradkar, had shown that neighborhood level SES is a consistent and significant predictor of developmental outcomes in children with special needs at school entry. What's more, when we compared the contribution of neighborhood SES by domain to developmental vulnerability in each domain for typically developing children and children with special needs, we found that those percentages were very similar, with an exception of communication skills and general knowledge, when it was higher for typically developing children, which may be explained perhaps that children go for need to access resources out of their neighborhood. I really don't know why, but at the same time, it's really quite similar, which really leads to the point that neighborhood disadvantage acts on children with and without special needs in a very similar way, which I am not entirely sure that this point is well acknowledged and considered while planning services and mental health supports or health supports for children with special needs and children with health disorders on a population level basis. Now, when we go to prevalence, so here we're jumping to all 3 or any of the 3 categories of health disorder, as I mentioned. We were wondering whether there was an association with social determinants of health, and specifically the ones that are covered in our SES index, which I have to mention that because it was constructed based on relevance of issues to early child development, it is a little bit more intersectional than the other SES indices that are commonly available for the whole population, such as Ontario Marginalization Index, which many of you are familiar with, and I'll mention a little bit in a second as well. So we certainly had enough variation to look at this association. The lowest percentage of children with health disorder in the neighborhood were 1.8%, and the highest was over 40%. And the green areas are the ones where their prevalences were higher. So, to a certain extent, you can think that maybe they were northern, maybe they were bigger, but there's quite a lot of variation in those here as well. So when we looked at the degree of association, we found that the results of linear regression showed a point R-square of 0.16. So there is some. But what was really, and so basically for each standard deviation decrease in neighborhood level SES, the prevalence of children with health disorders increased by 2.4%. When we added the province territory to the model, the R-square increased to 0.35. And that really tells us that the health, I think that indicates, maybe not tells us, but indicates that the provision of health services for young children, the pathways to diagnosis, pathways to services really vary widely across our country. And it was also brought to home by another analysis that we did by looking at teacher-reported prevalence of fetal alcohol syndrome disorder. Teacher reported, which meant that they had to be informed by either a caregiver or a health professional that this child has it. And FASD is notoriously difficult to identify early. It's difficult to identify prior to school entry. So we got a very, very small prevalence, but we looked at it for 3 groups: children with FASD only, children with FASD and at least one other diagnosis, and children with other neurodevelopmental disorders in the context of neighborhood SES and provinces. As well, we've put there a question of whether teacher felt that children may have had problems at home, which interfered with their participation in a classroom, and that could be a plethora of problems. So what we found was that children with FASD only was 0.09%, which was less than children with other NDDs. There was an association, was statistically significant association with neighborhood SES, and the highest disadvantage was for children with FASD and other comorbid disorders, even though they were a fairly small group. That was also the group with the highest prevalence of reported home problems, which was about 3 times as likely as for children with other NDDs. Now, excuse me. What I really would like you to look at is especially this comparison. So even though these percentages prevalence are really very small, what you see is that in Manitoba there is 0.2%, whereas in Ontario 0.04%. Are there really so many more children in Manitoba and actually British Columbia as well than in Ontario with FASD? No, but what is different is the pathways to diagnosis. And the colleagues I work with, especially Jackie Pei, who was the first author on that paper, was that they expected those differences to see in our data, and we saw them. And when we were controlling for confounders, children with FASD only actually scored consistently higher in the EDI developmental domains than children with other NDDs, which really raises issues about early identification and targeting and what it may mean long-term for trajectories of these children. And I understand that new diagnostic guidelines have come after the end of the collection of data for this particular analysis. And so we will be able to compare whether anything has changed. So 2 more kind of take-home points. Population data can help understand how social determinants of health are reflected in developmental health of low-frequency populations. And population-level data sets provide basis for cohort studies to explain the mechanism. They themselves cannot, but we're lucky to collaborate with colleagues at CHES and through the Target Kids study with Catherine Birkin and Jonathan McGuire to look in depth into those mechanisms. And they also provide the basis for system-level analysis through linkages with administrative data, which through POP data in BC, Manitoba Centre for Health Policy, and in Ontario through ICS, linkages with administrative health data, and EQAO with educational data. As you can see, we kind of reached a certain stage here that the population level data, they can explain, but they can help us ask questions. So this program of research was well positioned, and then this happened. This picture really speaks to me, which is why I included it here. There is a virtual exhibition at the Royal Ontario Museum. I encourage you to check out the other artwork that's there. So, and quickly, social determinants of health became commonly used terms. People everywhere, almost every day in news, there is evidence of inequities and geographic distribution. And people were asking questions about that because COVID really kind of put them to the fore. So this is the epidemic curve of the daily cases of COVID-19 in Ontario. And I'm going to talk a little bit about some information that happened from the first wave, and that was this wave. What's really interesting here is that these curves are also separated by the Ontario marginalization index, which has two categories: neighborhood diversity, which is mostly percentage of people of non-white and non-Indigenous, and also recent immigrants, whereas this one is material deprivation, which covers the common SES indicators such as income, education, etc. And so the lowest quintile is the people in yellow, and you can see that that they are more likely to they were more represented in the daily cases, but the difference for the diversity is way more marked than for material deprivation. In September 2020, based on information on cases, so this is the map of Toronto and cumulative cases, a list of schools was published that was deemed at risk for COVID infections in the new school year 2020. So it was a kind of dichotomous list. These schools in Toronto are at risk for COVID infections, and these ones are not, and they were based on the some indicators of the positivity and cases in their neighborhood. When we saw that list, we kind of thought, we wonder. And what we've done was we checked with the latest Ontario EDI data, which was 2018, whether there was any rhyme or reason associated with this categorization in terms of children's vulnerability at school entry 2 years prior to COVID. And what we found that the schools that were deemed at risk for COVID in Toronto in September 2020 were actually consistently doing worse. So they had higher vulnerability rates. They are the ones in orange in all domains of development 2 years prior to COVID. And, you know, a simple explanation is that because infection rates are associated with the same social development, determinants of health as the EDI vulnerability, but it also makes us kind of stop and wonder. So it takes a major pandemic calamity for us to pay attention to those. And we have indicators that already show us these inequities in on the ground, and we really are not that good at addressing them. So because we work with kindergarten children and we couldn't do anything with kindergarten children, we were quite lucky to collaborate with the 3 educators unions in Ontario, and we ran a survey of kindergarten educators. There is quite a lot of evidence that teacher closeness or well-being moderates children's learning in classrooms, so we were concerned about that. But we also were hoping then that we would be able to collect EDI data in the spring of 2021, so we wanted to have some kind of idea of what's going on in the classroom. So this study that's being analyzed and looked at especially by our postdoc Natalie Spadafora is another topic for conversation. I just want to highlight a couple of things. Over 80% of kindergarten educators told us that they were in touch with the student's family, but 11 told us that despite efforts, they could not. And also over 80% told us that there were children in their classes whose parents opted out of distance learning. And to be quite honest with you, I was concerned about those children. And I wonder whether we'll ever know to what extent this particular dropping out may have had an impact on their learning and lifelong trajectories. At the same time as we were conducting our study, Dr. Andrea Gonzalez from Offord Centre ran an Ontario parents survey. So that was a survey of parents of children under 18. And we coordinated some questions. So we've also asked the educators about their mental health well-being, using exactly the same questions as Andrea did in her survey. And we found the percentages of people experiencing elevated depressive and anxiety symptoms very similar in our 2 studies. So just over 50% of respondents had elevated depressive symptoms, and a third in Andrea's study and 25% in our study met criteria for moderate anxiety. And further to that, and that's a paper that we hope is going to come out quite soon, educators are parents too. So almost 2/3 of the educators that responded to our survey had children under the age of 18. And of those, 64% were primarily responsible for teaching their own children and looking after their own children. And we found that somewhat surprisingly to us at that time to be a major contributor to their mental health. So the people in brown, the educators who were mostly responsible for looking after their own children during the pandemic had the highest levels of anxiety and depression. While I didn't, just for clarity, I didn't show you the other groups, like the ones that didn't, and all of them, but the people who had children but shared responsibility for their care with another adult actually had the lowest levels of anxiety and depression. Okay, so I wanted to acknowledge that there are two elephants in this room. And the first one is the children's race. The only publicly available data that we have on the association between children's race, ethnicity, and EDI data specifically comes from the United States. We really don't have, and let alone EDI, any developmental data for relatively large population, represented populations in Canada. Most of our learning of the association between race and child development comes from other countries. So these data have been published fairly recently, last year, on the association between neighborhood socioeconomic index and children's EDI results for different racial ethnic groups. And as you can see, for each of those, there's the same gradient as we saw for all children in Canada. The slopes for white children is especially steep, whereas for the other groups, it's very similar. But what's really striking with this particular graph is that high socioeconomic status is considered generally to be a really very strong protective factor for child development negative outcomes. But what you can see here very starkly is that it's not such a powerful protective factor for Black children. So it's not very equitably, it's not acting very equitably. Actually, African-American Black children in the highest income quintile are doing only as well as white children somewhere between the second and the third income quintile. How does that look in Canada? We have no idea. Well, the second elephant in the room is actually a bird, but I really love this picture, and I love it because I used to love it because it shows that parenting is not an easy job. But I think actually talking about parenting in the pandemic, it really reflects the reality even better than before. The need to hover in the air while feeding your children or looking after your children and kind of dealing with unpredictability. I think it really exemplifies the challenges more than anything else. And next, and I'm not going to say more or less or whatever, but next to jobs in healthcare, I think being a parent has been a hugely challenging and difficult job in the past 18 months or so. And we talk quite a lot about the burnout for health service providers. And I have borrowed this set of issues that I needed in order to address the burnout and adopted it to talking about the burnout among educators as well as among parents. So we know that there is no healthy children without healthy educators. We know there is no healthy children without healthy parents. And those 5 points in terms of addressing burnout are ensuring that you are being heard, you are being protected, prepared for what is happening, supported when needed, and feeling that you are being cared for. And I think those 5 points are really coming across addressing the needs of parents as well as educators. But we really don't have very much good data on that. So here's another artwork from that exhibition, Make Germs Sick. So the vaccine makes COVID-19 die, apparently. 95% of the time. So what's next? So we've been really quite lucky to get funding for a project in this last round of CIHR to examine in more detail the socioeconomic gradients in children's development in the last implementation prior to pandemic, and it will be happening in 2022. And there's 5 provinces and 1 territory that are planning to collect data in 2022. We're going to try and, and so what has been, if you look at that phase 1 in the pandemic here, you see that the infections among children were pretty much, like the same, low, etc. Now we're going to come into school. These children came into school just about here. So with a history of infections among young children as well. So what we're going to try is to put into our models the information about the infection rates, as well as school closures and lockdowns. So we're all quite concerned that lockdowns and lack of school participation has potential for a lasting impact on child development and learning. Schools are more than just places where children learn. They are places for social development. They are places for testing your self-regulation, for sports, etc. For some children, they are also very safe places where if their home isn't all that safe. And so we're going to try and link the school closures that are happening right now as well to children's outcomes. It's not an easy job because every province seems to report these things a little bit differently, but I have collaborators in each of the provinces, and I have an excellent team, so hopefully we'll be able to look at that in a way that's informative, so to be continued. All right, so what I think is happening is, if you remember that social determinants of health report by Michael Marmot was called Closing the Gap in a Generation. Well, the gap not only is still wide open, it's actually gaping even wider thanks to what's been happening in the pandemic. And I'm not even, it's so in Canada, we think, and even more so in the rest of the world, in some other places especially. But obviously that's a topic for another conversation. But in order to address it, we really need good information, and we need to ask the right questions. And we have some answers to some questions that will help us do that. So pre-pandemic data are both useful and are a bit flawed because we may not have been asking sometimes the right information. So we won't really know necessarily how, for example, the pandemic has impacted the development of children who are racialized, because we never had collected those data pre-pandemic. But, and obviously the answer to the question that I posed to myself in the title is, heck yes, of course, pre-pandemic and historical data are crucial because we want to measure progress if we're making, and they are absolutely critical because we need to be accountable if we are not making that progress. So to end, I just want to thank my team and my colleagues who collaborated with me on a number of these projects and hopefully will in the future. And I would like to thank you for listening. And that's it. Thank you.
Great. Thank you very much, Magdalena. That was a terrific talk. And I just also wanted to say, so first of all, we have a huge audience and very happy to see 2 members of the Leong International Advisory Committee have called in. So that's really appreciated. Maybe I'll just start with a question. It's really striking that, you, in some ways, you have this amazing resource to be able to sort of, even though provinces are measuring at different times, you have this like incredible natural experiment, right? Because so many of the levers around child development are at the provincial level. But I wondered, how much there have been sort of whole scale policies and programming to try to improve, or reduce the gradient at least, or improve, school readiness across the country that you could then sort of be measuring and evaluating.
Well, that's a lovely question, Astrid. Thank you very much. And I promised everybody it was not a plant, but you know, actually the best example, that's a question that does come up quite often. And the best example is the full day learning in kindergarten in Ontario. And you know what, the jury is a little bit, the nuance of that is still a little bit out, but there is really, it was a universal intervention that was really, and I don't want to say that it's only, you know, EDI that contributed to it, but you know, there were plenty of things that that really contributed to this. But the fact that it was being allowed to be implemented at a quite considerable cost, and that the changes in the curriculum and in the setup were also implemented. So Ontario had a very specific schedule that you have two educators, right, in a classroom. So there's somebody who's familiar with early child development and somebody who's more familiar with pedagogy and learning. Several other provinces implemented full day learning without this particular model. And, you know, that certainly is something that we're trying to look at, but because, you know, it's not an easy task to compare provinces because there's so many other things that you need to account for, but that would be, to me, the best example. And there's examples at some other more local levels that also could be, have happened. The other thing is that several provinces, no longer Ontario, but several provinces have set up a table for tracking poverty reduction strategies, and they would take the EDI results year over year. That doesn't mean every year, but you know, in their kind of cycle of implementation as one of the indicators.
Thanks. Zulfi, do you want to ask your question? It's kind of actually a follow-on to mine. Or do you want me to read it? Well, go ahead. Yeah.
Well, thanks very much. I thought the presentation was brilliant and really consonant with what we are learning from the global experience on what's happened to children and learning. My question is very fundamental to what's happening in Canada in terms of policy reviews, some of which may relate to even tracking information that you alluded to is sadly not available in Canada, but also in terms of policies, innovations that may be put in place to redress some of this learning deficit that we are beginning to encounter, and how might we be able to overcome, if at all, some of this in the next couple of years. Just to underscore the final point, and that's based on the experience from other outbreaks elsewhere, such as Ebola and the consequences to learning from interruption of schooling or learning in those environments. Thank you.
That's an excellent question. Thank you again. Well, you know, there's quite a bit of information. I think with education, especially, what we have more so with child development is that majority of jurisdictions, especially in the developed countries, in the high-income countries, have been collecting some kind of indicators of children's education. And there's been a bunch of studies, one from Ontario by Scott Davies and Janet Orini, and there was another study looking at early child development led by Dana McCoy on the loss of learning. So there's been a lot of people looking at, based on data that we've had already, what is the loss, and the estimates tend to be quite huge. That there's going to be not just a year, but sometimes a year, and that loss could be quite different in different areas. And so in my perspective, I just hope that those papers that appear in peer-reviewed journals reach to governments that actually will have the same power to say, maybe we need to adjust the curriculum, maybe we need to make a difference here and there, which is definitely not something that I know. I'm not an expert in curriculum, not in pedagogy. But we can potentially see that some tweaks to the curriculum have the chance to make a difference in children's learning as things kind of set to normal. I really don't know whether that answers your question, but that's basically the reflection that I have when I look at those modeling research that are coming. And obviously in a few months, we're going to have not just modeling, but real live information on how much learning has been lost across the board. Yeah. I don't know if there's I answered your question.
Thank you.
Well, it's, yeah. Speaks to, you know, how much receptor there is on this, and maybe COVID's a bit of an opportunity, but, you know, yeah, not sure, you know, that we've had such great policy receptors, right, on this, especially around child development, where it has to be at least a couple of ministries together, you know, at the provincial level.
Yeah, and I think the other thing about the development education is that really it's very fragmented. So part of the problem is that, you know, in Canada, we don't have a federal education ministry, and anything you do through schools really is relies on support and I want to say cooperation, but, you know, there's more than that with the local ministers of education. And I'm really always in awe of the group that managed to put full day learning into legislation, because I think it was, it really was the perfect time for that to happen. It would not have happened at other times.
Yeah.
Oh, Catherine.
Catherine, you want to ask your question?
Hi, yes, super great talk. Really great to see it. Just curious about your thoughts on sort of the transactional relationships between learning and mental health. So, I mean, we expect mental health. I mean, we know mental health has taken a hit, and then that's going to impact learning. And then that sort of, you know, struggling in learning is going to bounce back onto mental health. And so I'm just curious about your thoughts in terms of, you know, the impact that this may have on sort of the transaction between those two variables, and what might be done from a policy or curriculum or this sort of level to sort of build both up, or should you build one up first and then address the other, or how would you see that working together? Thanks again. It was super great.
Okay. Well, thank you. You know what? I wish I had an answer, and you know that would be fantastic. Personally, I think so. This is an opinion, really. I think what we really need to pay attention to is how it works out across childhood. I think there will be differences in terms of what we see in 5, 6, 7-year-olds and what we see in 12, 15, and 18-year-olds. And I have hypotheses going both ways. Who is going to be more affected and who's going to be less affected? And you know that's a topic for a debate. You know, and really similar with the EDI, we were unable to put a hypothesis as to outcomes because we just don't know what's going to happen. So the learning and mental health, we all know, is so intricately connected. You can't have one without the other. And that's why I'm kind of thinking that this adjustment in curriculum, where the pressure is taken off students, especially in later grades, has really better chance to make a difference for everybody, than kind of thinking that those two things are different. I also believe, you know, like, with my personal background, you know, family members who had lived a childhood during the Second World War, there's a huge resilience in children. There is an opportunity to bounce back from really horrific experiences if you have your family around, if your family was able to cope, and which is why I put the parenting here as a second element, because, you know, it's not enough to support children in classroom. Their families have to be supported as well. So these are kind of personal opinions. Okay. Was there?
There's some other questions in the chat. Catherine, do you want to ask your question?
Hi there. I think you got the Catherine Cost before, but thanks, Magdalena, for a wonderful presentation. I was wanting to hear your perspective on the EDI, which is, you know, a teacher-reported tool, and we don't have that many reported tools from other people in children's lives. So I wondered what you thought about that.
As in validity or?
Yeah, validity. Should we be doing more of that? Should we be
okay.
measuring children from different perspectives?
Mm-hmm. Yeah, no, great question again. And so, yeah, the different perspective, that's a lovely question, because, I obviously have an opinion on that. I really think there is no perfect assessment. So sometimes you come into the room with people who run direct assessments, and they say, oh, that's the assessment. Anything else is subjective. Well, I'm sorry, but actually science shows that you also project a certain, there's a possibility, besides majority of cognitive assessments are language mediated. So if a child is not doing very well in the language, they will not do well in math, etc. So there is a, and obviously parent assessment is also biased to a certain extent. They only have the children they have, and so their judgment is biased that way as well. So I really believe that in order to get a really full picture, you can't do that at the population level. That's just too impossible. But you really need different informants, and I truly believe that you have it is possible to get reliable and important, and the question of what's the definition of reliability, important and relevant information about adolescent mental health from the adults in their life as well. And sometimes people may not be all that willing to say what they think of what they have, and the observers may judge it a little bit in a different way. It's not necessarily whether one is better than the other. It's what different aspects of children's lives they shine a light on. So that's kind of what I think about that. But
thanks. We have a couple more questions in the chat. If you're maybe one more quickly, Dylan, do you want to ask your question?
Yes, thank you so much for the talk. It was very interesting. I was wondering, with the EDI specifically, have there been studies looking at family-wide versus child-specific differences? So when looking at those gradients, I was thinking, especially in light of your discussion of parenting, which I really appreciated, how much of that variability is reflective of household differences versus how much is reflective of environments that are specific to individual children?
That's a great question, but unfortunately, we are unable to answer those because of the, as I mentioned, through the work with Target Kids, there's more information on the family, and maybe eventually we'll be able to do something like that with Catherine. But at this point, the data are shallow, kind of, so we don't have information on families. The reason we are able to collect population level data is because we don't ask for individual information on the child's name, address, and family. So we have postal code, but that's the closest that we come to the family. So, so unfortunately, I can't answer that question, but it's a good one.
Thanks.
Oh, we actually then have time for one more. So Kimberly, do you want to just ask your question and then we'll wrap up?
Sure, thank you. Thanks so much for this talk. I'm one of the pediatrics residents. I'm sorry if you might have already touched upon this, but I was just wondering if when we're talking about differences in literacy and language development in kids, if we control for differences in terms of primary language spoken at home. So for kids who at home might speak another language primarily with family versus ones that speak English at home.
Yes, we do. So we do sometimes, mostly we control for a variable called English language or French language, because we collect data both in Anglophone and Francophone schools, whether the language of instructions is the child's first language or not, because there are children who whose first language is not necessarily English or French, but they're fluent in the language of instruction, and then usually their outcomes are not affected the same as when they judge ELL or FLL. And yes, we control for that in our analysis. So, okay. Could I just say congratulations? Could I just say congratulations to Catherine Birkin on her chair? But yes, I just want to say.
Absolutely. Congratulations to Catherine. We're looking forward to the official sort of announcement tomorrow, Wednesday evening. So yeah, as the first Leong chair. So Magdalena, thank you very much. We will be very interested to hear what your EDI work this spring in Ontario shows. And again, you've been all of us who have collaborated with you from here, are really, really grateful for the collaborations. I think this is a hugely important area. And I think back to sort of Zulfi's point and where I was going, you know, it's hard to imagine that things aren't going to look, you know, the disparities aren't going to look worse. And I think, you know, we probably collectively need to be thinking about what we do with that and how we push on it. You know, and again, I think that's a whole of government kind of problem, not just one ministry, but I think we should be, you know, trying to take all this excellent work and trying to, you know, make some change. So I know that sounds very generic, but, you know, again, I think that it's just critical. So, so thank you very, very, very much for an excellent talk, and look forward to lots more work together.
Thanks very much. I really appreciate the opportunity to speak here. It was great.